Heart failure is basically a condition in which the heart is unable to produce adequate cardiac output, and in so doing is unable to meet the body's metabolic requirements. The cardiac dysfunction may predominantly involve the left or the right ventricle, individually or both ventricles simultaneously. The latter case is termed biventricular failure or congestive cardiac failure. The functional classification of heart failure using the New York Heart Association classification is described as class 1, class 2, class 3, and class 4. So for class 1, no limitation of physical activity. Ordinary physical activity does not cause undue fatigue, palpitation, or dyspnea. Also, for class 2, slight limitation of physical activity, comfortable at rest, but ordinary physical activity results in fatigue, palpitation, or dyspnea. Class 3, there is marked limitation of physical activity, comfortable at rest, but slight activity causes fatigue, palpitation, or dyspnea. Class 4, unable to carry out physical activity without discomfort. Symptoms of cardiac insufficiency are present at rest, and if any physical activity is undertaken, discomfort is increased. Causes are systemic arterial hypertension, rheumatic heart disease, cardiomyopathies, severe anemia, ischemic heart disease, thyrotoxicosis, congenital heart disease, pulmonary arterial hypertension, and cardiac arrhythmia. Symptoms for left heart failure are breathlessness, usually on exertion, on lying flat, that's autopnea, and at night, that's paroxysmal nocturnal dyspnea, and also easy fatigability, cough with frothy blood stained sputum, and wheezing. For right heart failure, it's usually swelling of the feet and lower extremities, and this may be present in children below 6 months. And also abdominal swelling and right hypochondral pain from an enlarging liver. The signs that are usually elicited for left heart failure are tachypnea, tachycardia, basal crepitations, gallop rhythm, displaced apex beats, cardiac murmur, and rhonchi. The signs of right heart failure are tachycardia, pitting pedal edema. This may be absent in children below 6 months. And also ascites, tender smooth soft hepatomegaly, raised jugular venous pressure, gallop rhythm, and cardiac murmur. In children, signs are failure to thrive and difficulty in feeding. Investigations: FBC, ECG, chest X-ray, blood urea, electrolytes and creatinine, and EGFR, that's estimated glomerular filtration rate, and liver function tests, fasting blood sugar, fasting lipids, echocardiography, thyroid function tests, cardiac enzymes, if myocardial infarction is suspected, and also coronary angiography. Treatment objectives. The main treatment objectives are to relieve symptoms and improve quality of life, to treat the precipitating cause, to treat complications, to prevent recurrence of symptoms, to reduce the need for hospital readmissions, and also to reduce mortality. Non-pharmacological treatment: reduce salt intake, reduce weight in overweight and obese individuals, avoid alcohol, avoid or quit smoking, encourage moderate exercise, bed rest, only in acute heart failure or exacerbations of chronic heart failure, proper PIN bed. Pharmacological treatment: for acute heart failure, the initial treatment, you give oxygen. That's for first line treatment. You give oxygen by nasal cannula or face masks if there is hypoxemia, that's SpO2 less than 90%, and you add furosemide IV in adults 40 to 80 milligrams, and repeat after 30 minutes if necessary. In children 12 to 18 years, 20 to 40 milligrams repeated 8 hourly as necessary. And for 1 month to 12 years, give 0.5 to 1 milligram per kilogram repeated 8 hourly. The maximum dosage of 4 milligrams per kilogram per dose. For acute heart failure, maintenance treatment after stabilization, you give furosemide IV in adults 40 to 80 milligrams 12 hourly. In children 12 to 18 years, you give 20 to 40 milligrams repeated 8 hourly as necessary. And 1 month to 12 years, 0.5 to 1 milligram per kilogram repeated 8 hourly with a maximum dosage of 4 milligrams per kilogram per dose. For acute heart failure, and a patient not improving after initial treatment, you give furosemide IV. Adults 40 to 80 milligrams 12 hourly. In children 12 to 18 years, give 20 to 40 milligrams repeated 8 hourly as necessary. 1 month to 12 years, you give 0.5 to 1 milligram per kilogram repeated 8 hourly. The maximum dosage of 4 milligrams per kilogram per dose. Also, you give morphine IV. Adults 5 to 10 milligrams slowly. In children, it's not recommended for this condition as safety is not well established. And then you give metoclopramide IV in adults 10 milligrams to prevent vomiting. In children, it's not required. For acute heart failure, and patients improving after initial treatment, you give furosemide oral in adults 40 to 80 milligrams 12 hourly. In children 0.5 to 2 milligrams per kilogram 8 to 12 hourly. For acute heart failure, in patients with fast atrial fibrillation or in sinus rhythm with systolic dysfunction, you give digoxin oral in the elderly 125 micrograms 12 hourly for 24 to 48 hours, and in adults 250 micrograms 12 hourly for 24 to 48 hours, and then 250 micrograms daily, and then 125 as 125 micrograms daily. For children more than 10 years, use 0.5 to 1 milligram in 3 divided doses over 24 hours, and then 62.5 to 250 microgram daily. And children 2 to 10 years, give 20 to 30 microgram per kilogram in 3 divided doses over 24 hours, and then 8 to 10 microgram per kilogram daily. In children less than 2 years, give 30 to 40 microgram per kilogram in 3 divided doses over 24 hours, and then 10 to 12 micrograms per kilogram daily. Neonates, as full term, you give 20 micrograms per kilogram in 3 divided doses in 24 hours, and then 8 to 10 micrograms per kilogram daily. Neonates less than 1.5 kilograms, you give 25 micrograms per kilogram in 3 divided doses in 24 hours. And premature, give 15 micrograms per kilogram daily, and then 5 micrograms per kilogram daily. In acute heart failure, in patients in cardiogenic shock, that's adult systolic blood pressure less than 85 millimeters mercury, with hypotension or hypoperfusion, you give dobutamine IV infusion in adults 2.5 to 10 micrograms per kilogram per minute. ECGs should be monitored continuously because inotropic agents can cause arrhythmias and myocardial ischemia. For prophylactic anticoagulation against venous thrombosis, you give enoxaparin SC, that's subcutaneous in adults, 1.5 milligrams per kilogram, 150 units per kilogram daily, and in children 2 months to 18 years, you give 1 milligram per kilogram 12 hourly. 1 to 2 months, you give 1.5 milligrams per kilogram 12 hourly, and in the neonates, you give 1.5 to 2 milligrams per kilogram 12 hourly. Identify and treat, if possible, the precipitating causes such as hypertension, myocardial infarction, anemia, or thyrotoxicosis. For symptomatic heart failure, first-line treatment, you give furosemide oral in adults 40 to 80 milligrams daily, and children 1 to 2 milligrams per kilogram daily, and lisinopril oral you give only when systolic blood pressure is more than 100 millimeters mercury, and for adults 2.5 to 20 milligrams daily, or you can give ramipril oral. That's only when the systolic blood pressure is more than 100 millimeters mercury, in adults 2.5 to 10 milligrams daily, and then you add carvedilol oral, adults 3.125 to 12.5 milligrams 12 hourly, with a maximum dosage of 25 milligrams 12 hourly, or you can give bisoprolol oral in adults 1.25 to 10 milligrams daily, or metoprolol oral in adults 25 to 100 milligrams daily. So patients not tolerating ACE inhibitors, we replace lisinopril or ramipril with the following, as in first-line treatment, as stated. You give losartan oral in adults 25 to 50 milligrams daily, or candesartan oral in adults 4 to 16 milligrams daily. In patients with fast atrial fibrillation or in sinus rhythm with systolic dysfunction, you add digoxin oral in the elderly, 125 micrograms 12 hourly for 24 to 48 hours, and then 125 micrograms 12 hourly in adults, 250 micrograms 12 hourly for 24 to 48 hours, and then 250 micrograms once daily. In children, 5 micrograms per kilogram 12 hourly. For symptomatic patients, in spite of the medications I mentioned, you add spironolactone oral in adults 25 to 50 milligrams daily. Referral criteria: all patients must be referred to a specialist when clinically stable for the identification and treatment of the underlying cause of the heart failure, and for long-term maintenance therapy. Okay, so let's look at the flow charts. So symptoms and signs of heart failure. Acute onset, you start pharmacological treatment of acute heart failure, and for non-acute onset, initiate the following treatment: lisinopril or ramipril, carvedilol or bisoprolol or bisoprolol, also furosemide, digoxin, and spironolactone. And then for both acute and non-acute onset, The investigations, ECG, chest X-ray, BE, creatinine, LFTs, FBS, FBC, lipids, and echocardiography. And after that, you refer all patients to specialists for further evaluation and management.